All right, I'm back in plenary session, virtual edition. I'm joined by Dr. Mark Gorelik. Dr. Gorelik is a pediatric rheumatologist. He's a pediatric immunologist, and he did his pediatric residency in Children's Hospital Cincinnati. He did 2 fellowships, rheumatology and immunology at Hopkins. He is at an academic medical center. He's a researcher, pediatrician, and very thoughtful interpreter of data. Mark, thank you so much for joining us.
Sure, thanks.
So we're here to talk about the big issue, which is pediatric myocarditis. I wonder if you might take us through your thinking on this issue and walk us through where you are on this.
Right. And so, I just, before I want, I think it's always important also to just talk about the context, that we're in. Because, these things tend to get misinterpreted and, and sort of wildly can be taken, wildly by some groups. And I think that it's clearly important to stress that.
Okay, you were saying, let's start by saying it's important to start off by stressing a disclaimer.
Yeah. So
vaccination is important. I think that's where you're going with this.
Yeah. So what I wanted to say is that for adults, COVID, as a disease, and it sounds obvious and it's been repeated, but it is a very, very serious disease. And as a pediatrician, because of our experience with MIS-C, we were consulting occasionally with adults with COVID to kind of help the adult hospital determine whether this was COVID or MIS-C. So I have a little bit of familiarity with, the adult phenotype of COVID, and my reaction to seeing those patients was that it is almost as though somebody has taken a biological equivalent of an atomic bomb and dropped it on those patients.
Mm-hmm.
That is how sick those patients are, and that's no joke. And I think that the other thing to stress too is that although we are seeing decreasing mortality with hospitalizations, part of that is due, first of all, part of that is due to being vaccinated. And part of that is also due, though, to the way that I think physicians have learned how to tackle COVID. And when when you sort of leave the hospital alive, it's not that, it's great that you didn't die, but there's an asterisk to that. A lot of those patients leave on oxygen, or they leave to palliative care.
Mm-hmm.
They're alive, but they are mangled.
Mm-hmm.
And I think that it is, for an adult individual, it is just critical to be vaccinated, and not to misinterpret, any of the sort of nuance, which is, in this, because that's not what that's about.
That's really an important disclaimer, I think, to start with, because it is a catastrophic disease.
And I wouldn't even say it's a disclaimer. It's a sincere statement, really.
Yes.
It's fact.
It is a fact, yes. That's well put. And so you'll encourage any adult to get vaccinated, particularly older people. It's log gradient. I mean, it's devastating if you're older. It's playing Russian roulette to go out there if you're an older person and you're unvaccinated. Yeah, it's a death wish. Okay, let's talk about, and that's important, and I'm glad you started with that. Now let's also talk about the value of vaccination in pediatric history. Vaccines for kids have been an important thing.
Right. No, I think as a pediatrician, you have to, understand that pediatrics is a totally different field now than it was, 40, 50 years ago because of vaccination. So, when we were training as residents, what we didn't have, thankfully, were all of those kids who, and the older doctors would tell us, every night I was on call, there were 2 or 3 patients with pneumococcal meningitis. and that's a disastrous disease. And so, vaccination in general, for all infectious diseases, is probably the most potent tool that the humanity has ever developed to fight disease. So in general, there's no, these are all obvious things, but they need to be said.
Okay. And they need to be said because I think it's important for you to be on the record as saying, you think it's a very serious illness, particularly in adults. You think vaccination is an important good. And
Right.
when we talk about myocarditis, what your goal is you want to vaccinate children as safely as possible so they
Right.
get most of the benefit
think-
and least harm.
I think that is sort of the nuance, and I've been obviously thinking about this a lot because I'm also a father. I have children, and in general, there is no doubt in my mind that it is better to be vaccinated than not vaccinated, and that just by the way, we are seeing in pediatric hospitals more admissions now. And it's sort of, I don't know what the word is, ironic, but that at this point in the pandemic, when so many times in the past there have been these press reports of lots of children being hospitalized. At this point, it actually is the most true, put it that way, that because of this just sheer number of cases. If you think about 1 million people got infected today, there's
Correct.
going to be kids coming to the hospital. So overall, it is definitely better to be vaccinated than not vaccinated. The nuance is a couple of things. One is how to do that super duper, how to do that safely. And then I think also coming to, what the point of it is, what the point of being vaccinated is, and how that relates to boosters for children. Because that's, I think, where I worry that we are moving beyond the benefit. And, if you think of sort of a diminishing curve, a diminishing returns curve, we're going on the other side of that curve.
Right. So let's start with that. Let's start with, vaccination, I think, in adults have several goals. One is when you do encounter the virus, which you will out there on the streets, your probability of getting very sick, getting hospitalized, and dying is substantively lower if you're an adult who's been vaccinated than if not. And I think that's an important good. There was initially a hope that the other good of vaccination would be that vaccination would sterilize you, so that if you were to come in contact with the virus, you would not be able to even get it in your nose and not be able to give it to another person. That was a hope.
Right.
But at this point, I think it's revealed that hope was, like all hopes, hopeful, but it didn't happen. And now, right, okay.
So my understanding is that, the World Health Organization, the head of the World Health Organization quoted a number, and I don't know where that number came from exactly, but he said that the vaccine is about 40% effective in stopping transmission.
I see.
Which is, something, but it's certainly not what you would need to have like a herd immunity kind of effect.
And with that vaccine efficacy at halting transmission, coupled with the fact that the R coefficient of the virus has exploded with Omicron, you don't have herd immunity. You have 100% saturation of a population with this. Yeah. So inevitably, we will all, be exposed. It won't extinguish. It won't diminute. It will eventually expose us all. And at some point, I might get a runny nose, even though I've been vaxxed and going to be boosted as much as anyone else, as much, I might get a runny nose, but that's okay.
Right.
Let's talk about, let's talk about myocarditis. Let's talk about it in a couple ways. One, I think, I follow this really closely, and the first time it was brought to my attention was February 2020. I saw an article in the Jerusalem Times. It was sent to me. It said the Israelis had noted in men 16 to 19 the signal that there was myocarditis. And the Israelis, I think, are good at having passive surveillance. They're good at tracking. They were ahead of the curve when it comes to using Pfizer. And they had noted that this mRNA product was linked to myocarditis. They didn't know the exact rate. Yeah.
You said February 2020. I think it's February 2021.
2021. You're right. 2021. Of course. It didn't predate the whole thing. Yeah, 2021. Yeah. Well, I forget what year I'm in. 2022.
No worries.
Okay. Yes. February 2021. That was the first signal. And then over in I believe May 7th, the EMA launched the inquiry into myocarditis. I think our CDC was a little slow to acknowledge it, but by the summertime, the CDC had said, yeah, this is a real thing. The estimates have always been divergent. We now have some new data from Kaiser Permanente. We have data from the United Kingdom. But I would be happy to say that for a boy between the ages of 12 and 24, maybe the risk is something between for clinically overt myocarditis leading you to seek medical care, 1 in 3,000 to 1 in 6,000 ish. What do you think about that ballpark?
Yeah, I mean, I think it's reasonable. I mean, I usually say 1 in 5 to 1 in 10, but
Okay.
I think that the way that would be described as just non-trivial. It's not nothing.
It's not nothing. And let's also talk about there's something beyond this, which is if you took every boy in that age and you drew their blood and sent it for troponin after vaccination, we've not yet done that. That's a post-marketing commitment that Pfizer has. And there are other experiences with vaccines suggesting that the tip of the iceberg, the clinically overt syndrome, may not capture the full iceberg.
Right.
Is that something you think about?
Yes, and I think you have to be very careful about that because we don't know. And you have to sort of judge, what we do know. I think it's important to talk about what we do know. And the things that we don't know, although there are, one has concerns about the rate of subclinical myocarditis, we just don't know it yet. And so, I don't want to, make it out to be something that it's not because we just don't have the data.
Okay.
But it is, I think that it's always likely that whenever you have, any kind of event like this, there's going to be more of it than you are aware, and more of it that's seeking medical care. And so, whatever that rate is, again, there is a higher than what one would want rate of this, adverse effect. And I think that the issue that is mainly concerning with that is, the character of it and whether that is something that will have, transient effect or more longer term effect
Let's come to
on
that. Yeah.
these kids. And so that's something, I am sort of I'm a funded researcher, and I do research in cardiac immunity and cardiac immunology and cardiac inflammation as part of what I do. And part of that was also working with patients with MIS-C. And, one of the things that we were always concerned about with these patients was that the inflammation in the heart would subsequently cause damage, which is what happens with inflammation. After you get inflammation, there is fibrosis. So this is, inflammation, fibrosis. So that's what happens.
And fibrotic tissue is non-conductive tissue, which can lead to scarring and arrhythmia.
Right. So, and so because of that, we had sort of done some research looking at that, and it turns out that in these patients with MIS-C, the way that you wanted to look at whether they have damage from the inflammation is through cardiac MRI, where you basically take a look after the course of their disease and see whether they had a specific kind of signal, which is indicative of fibrosis, basically. And reassuringly, the majority of these patients did not have that with MIS-C. And so that's important. However, once the patients with the vaccine-associated myocarditis were coming in, it appeared that in a substantial minority of those patients, there is that signal on the MRI.
And this is the late gadolinium enhancement.
Right.
And
so,
it's on a T2 weighted MR, or what is the weight?
So, the technicality is, I'm not going to kind of get into that. But basically, it is, very loosely the way that, contrast is sort of absorbed into tissue and how quickly it washes out. And you can kind of imagine that if you've got, collagen in your heart and fibrotic tissue, it's going to be a different rate than it would be in the normal surrounding myocardium. And so that's why you can see it.
So let me just unpack a little bit for a second, because
Yeah.
I think you made so many good points. So I guess one point is we were talking about that under the iceberg troponin, and your point is that we just don't know what we don't know. Well taken. Pfizer has 5 years to do that post-marketing study. I think they should have 5 weeks to do it, but that's my opinion. They've taken too long. Yeah.
I think that it is a concern, and I think that that we should have that data sooner.
Yes. The next point you're making is that when you look at MISC and you look at myocarditis post-vaccine, these are to some degree idiosyncratic. At least myocarditis post-vaccine is an idiosyncratic adverse event, and those will have a distribution. And there may be a lot of people with sort of mild symptoms and maybe mild physiologic changes in the heart. And there may be some people with tail symptoms who have more pronounced physiologic changes in the heart. And so when I see things like people say, well, it's mostly mild or it's mild, they forget that may be true for a lot of people, but there's going to be somebody who is a 12-year-old or 15-year-old boy who is perfectly healthy, who is going to have something that's not mild. And that's something to be taken seriously.
Right. I think that the way that I would sort of talk about that is that, Miss C is clinically very impressive. These patients are very sick.
Yes.
And remarkably, many of them, most of them, a majority do well. When you're talking about the vaccine-associated myocarditis, clinically, these patients are mild in that, they are not requiring, intensive kind of care level therapy, but they also will have, in some cases, findings later on imaging that we just don't know if those findings are really benign. I think
so. Yeah, it's possible.
Right.
It's possible that even though they clinically don't look as sick as the MISC, they may have more long-term cardiac issues than an MISC person.
It's I'm trying to stay away from comparisons because I don't think it matters. Right. It doesn't really matter whether it's how much more or how much less. I think it's just important that we sort of acknowledge that it's real and that it exists, as opposed to just saying, well, it's mild, it's rare, it's transient, and you're done with it. There is mild transient pericarditis, where people with lupus or people with other, immune diseases have just inflammation of the pericardium, and that just goes away, and it's mild, and it is truly mild and transient. And I think that the description of it makes some people think that this is what we're dealing with. And I've actually had some people say, well, that's all it is. But it's not. It's different in that, it actually affects the myocardium, and it actually, in some cases, leaves imaging changes that, although we don't know the ramifications of it, and although they seem to be hopefully evolving in a positive direction in these patients, the bottom line is that I think that as a parent, if you were a pediatric cardiologist or a doctor and your child had those imaging findings, you wouldn't be thrilled.
You wouldn't be thrilled. Yeah. Let me ask you this though. I take your point is well taken that comparing MISC to this, it's not very fruitful. It's not very useful. But I think there are several questions that a person will face, and these are real questions, and you'll have to make some comparison. Here are the questions. If you're a 16-year-old healthy boy who's never had COVID, should you get the first dose? And I think that the risk-benefit actually is quite favorable to the first dose for that 16-year-old healthy boy. The second question is, should you get the second dose 21 days after the first dose? And that's a question that I think. And then the third question, should you get the second dose 56 days after the first dose or 96 days after the first dose? And then the next question is, should you get the second dose at all? And then the final question is, if you've gotten 2 doses and you just got Omicron, should you get the third dose? So, and this is where what people don't capture is that's where the scale is really tough.
Yes. No, I think it is very nuanced there. And, as I said, I've kind of been thinking about this, how one would sort of describe this issue that we're facing. And it sort of occurred to me that it's kind of like a medication that has a narrow therapeutic or relatively narrow therapeutic range.
Mm-hmm.
This is an important vaccine. It works.
Mm-hmm.
And it is better to be vaccinated than not to be vaccinated. And I think, if you're a 16-year-old, the question is not, should you be vaccinated? The question is, how should you be vaccinated? Because there is a little bit of a narrow therapeutic range, and at some point, there is risk, and it's important to just try to mitigate that as much as possible, so that you can be vaccinated. And I don't know the answer to that, how it should be. I think that if you were sort of referencing 56 days, which I think references that Canadian study,
Right.
And I think that's a very important graph. I think that if you were able to throw it on here just to show people, I think it's very important to see that.
Yeah, I'll put it on.
The rate of the incidence of myocarditis, if you sort of delay that second dose, drops tenfold by just that simple fact, that simple intervention, and that's huge.
One thing I have to have you say is that
that's something that,
yeah. Some people think that if you aspirate the syringe, you won't get this problem, but this is an immunologic phenomenon. Don't you agree?
Yeah,
Yes.
I think you can't go around, asking people, well, can you aspirate or not? And that's sort of silliness, I think.
Yeah. If that were true, then why would it happen far more common after dose 2, and why would it happen more common if you give it early than later? It's immunologic. It's not vascular.
Yeah.
Yeah. Okay. So, but let me ask you this. I agree with you about the 16-year-old. You have a 5-year-old healthy boy, and the 5-year-old just had COVID.
So, I don't know what to tell you, quite honestly.
Yeah, that's a problem. I think
that it's reasonable for that child to get another dose of vaccine, because that's 2 doses.
You're counting the Omicron as the first. Yeah, I see.
Whether they need more than that. And I understand the idea, and I think a lot of this is, sort of gets then into this idea of, well, and that's where I worry a lot about this, the idea of, well, there's just you have to have set rules, and everybody has to follow the rules, and there can be no exceptions. And so whether or not you've had COVID or not, you just need 2 doses, the end. And then that steps further, into this idea that parents are not able to kind of talk with their provider about this and about what, they feel, because really there's just not a whole lot of evidence there. So it's to me, it's okay when you're operating in that kind of gray space to kind of say, hey, what do you think? This is where I'm comfortable with things. I would prefer that they only get 1 dose, etc., or, whatever. I, as a pediatrician, am not going to sort of badger somebody, on that. I think it's important that the child is immune and vaccinated. But, how exactly the parents want to achieve that is sort of
yes, I see.
Partnership between us.
Well, your position is very similar to Scott Gottlieb's position, the, board member of Pfizer, former FDA commissioner. That's my position too. But I think we got to point out 2 things. One, who put us in this situation? Who put the pediatrician and the parent, who put these 2 people in this situation? And the answer is the regulator. The FDA put them in this situation. Why? Because the regulator ran a randomized controlled trial with just a few thousand kids in it. And if you run a randomized trial with a few thousand kids, you have no power. You have no power to see a reduction in severe illness. You have no power to see an interaction coefficient between prior infection and not. And in fact, in the trial, among the fraction of kids who had prior COVID, there appeared to be no cases of COVID in both control and intervention arm. You have no power to see myocarditis. And I think that's inexcusable because there's no shortage of appetite to enroll in that randomized trial. The trial would have enrolled 5 million children if they wanted, because 5 million people got it, lickety split. The appetite was massive. It puts everyone in a
Right.
difficult
No,
situation.
I think it,
Yeah.
right. I think it's true. I was watching another podcast where, Paul Offit was talking about this and saying, well, maybe there was never enough. Maybe certain people would not be satisfied with, 30,000 or 300,000. It would just never be enough for certain people. And maybe that's true, that there are certain people who just never want to be vaccinated. There's nothing you can do about that
That's
group.
true.
But I think
Yeah.
that group is a minority. And that I think most parents would, you know, have a number that they would feel, okay, this number of kids has been trialed, it's safe, and I think a lot of people felt that that number was too small, and
I
once
guess,
the cat is out, then the
yeah.
cat's out of the bag, and you're
Yeah.
sort of now stuck, and that's something I think you know that we haven't thought about a lot in this whole pandemic is the idea of what are the things that we're doing that might have inadvertent harms, and even because we think that it's a good idea to do a very small trial very quickly, et cetera, et cetera. But there's sort of an inadvertent harm. We didn't realize that there will be this adverse effect, and now we're sort of left studying it once it's out in the world and in a real world setting, and it's not the best place.
Yeah, because the lack of controls. I mean, I guess my point to Paul Offit would be, I'm sure it's true. There's a lot of people out there, I won't label them, there's a lot of people out there who no trial will ever sate them. But for those of us who are scientists,
Right.
there's a simple threshold, and that threshold is show me net clinical benefit. Net clinical benefit, which is you avert more bad things than you cause. And to do that, you could do it with probably 50K to 100K for that age group. But in the 80-year-old age group, you don't need 50K. You only need 4K. I mean, 4K, 2K, you'd probably show that with
Right.
80-year-olds lickety split, So there is, I think, a sense to it.
Right.
Let me ask you
And I
about,
think you could have
yeah,
had lower numbers too. I think, I think 30,000,
for children.
whatever,
Okay.
um, yeah, would be
Depends on
reasonable.
how long you follow and and it depends on what's going on at the time. The event rate you can't control. If Omicron sweeps over, 10,000 sample size sufficient. If Omicron
Right.
doesn't sweep. But let me ask you, I mean, I think Omicron introduces some challenges because we are poised to have, we've already had mandates. I mean, the mandates are here. There's workplace mandates for men between the ages of 18
Right.
and above. And now there's booster mandates. I mean, there's this 18-year-old. He's an IT worker. He's at a hospital. He's doing remote work. He's already had 2 doses of Moderna. He's got 100 micrograms in his arm, 200 micrograms. And now this person is being told, if you don't get that booster by whatever, you're going to get fired.
Yeah.
What's the risk benefit proposition? And then let's just say this person, their nose just dried up because they just had Omicron. So they got 2
Right.
Moderna and an Omicron, and now they got to get boosted within the next 4 weeks or they're fired.
Right. And, I think that is, by the way, if you listen to the Verbeck meeting, at when they discussed boosters for all of the folks who were under, 60 or sort of the 16 and up, a number of the committee members mentioned this concern that, they wanted to see this vaccine be approved so that it could be used by those who wanted it, but it shouldn't be, sort of a mandated process, because, we're kind of, you don't know, we don't know the sort of risk benefit completely. And I think that when you're talking about mandating, a booster, a person who's gotten 2 shots is evidently protected from severe disease, and a young person then getting another booster is really now only moving from whatever benefit they have. They're not getting any more benefit. They're on the top of that diminishing returns curve, and they're going on the other side, where now they are at getting this non-trivial risk of having this myocarditis, which is not nothing, um, and and the problem is that this becomes sort of misinterpreted, I think, by a lot of smaller organizations, small it's interesting to see kind of where the mandates are coming from. They're all coming from very small, private organizations, little preschools, little this, all of the kids have to be boosted and etc. They're not really coming from the states. They're not really coming from, and there's a reason for that. There's a reason is because the states who have the resources know that that's probably, they don't want to do that because it's tricky.
It also comes from culture, political culture, because Los Angeles is very draconian, but they're very left of center. Some of these preschools, these avant-garde preschools, they're very, But your point is well taken. Let me ask you this, just as a thought experiment. If I took a 16-year-old boy and I gave him Pfizer vaccines every month for a year, 12 shots, okay, what would happen to the benefit for severe disease? They'd get a lot of it with dose 1, a little bit more with dose 2, and they'll plateau. You're getting a saturation effect. You can't have a further reduction in severe disease. What would happen to risk of myocarditis? It would explode. With each additional dose every month, it will go higher and higher. Now,
and we don't know that, but I think just probabilistically, you're sort of playing a game there with that's going to end badly, and it comes down to trying to always think about the harms, I think, and that we haven't done that a lot in this pandemic, and we've sort of gone to the idea that, well, if some is good, more is better.
Right. That's the American idea for everything.
and I think that it's important to just sit back and say, well, let's try to make sure we can balance these risks and harms. The same thing I think went for school closures. We didn't think about that at all. Some people did, but not enough.
Some people did. Some people.
And I think it's a similar lesson in sort of, making sure that we are not, in the trite phrase, not doing harm. And there's a reason that phrase has permeated medicine. It's to make the physician think about harm. When they said don't do harm, it wasn't don't chop off the wrong leg. It was to make you think, where is the harm? Because I'm a physician, I can cause harm very easily. And it's the same way in public health. You can cause a lot of harm with all sorts of measures. You have to think, where is the harm? How can I avoid doing the harm? And I think, when you come to these situations where you're just approving the booster for 16-year-olds and 13-year-olds, without having your committee meet on it, then what the harm becomes is that various universities are now demanding that 18-year-olds need to be boosted when they come back to college, and they're really over. Now again, I think it's always important. Like as an individual, your actual risk is probably very low, but over the population of all these college kids coming back to college, there is going to be a net harm.
And I guess that's the point that, there's two things I want to say. One is many things in medicine that have harmed a lot of people have been done by self-righteous people who thought they were doing good. So that's just a point to make. In the history of medicine, we don't know.
Nobody who insists on something thinks that they're doing the wrong thing.
Correct.
Nobody,
okay. No. Yeah.
That's
but and history has
humanity.
Taught us many times that we were wrong. Okay. And I guess the whole purpose of this conversation is your point's very clear, which is that you don't and I don't know with 100% assurance the right answer. But I do spend a lot of time thinking about data, and I do get a sense of what are the populations and all the questions I ask you are the toughest ones. The 5-year-old boy who just had Omicron, the 16-year-old who had 2 doses and Omicron, these are the most equivocal. But as you say, the mandates are blunt. Your point about the college policy, I think one of the things people have argued is that we should accept if we have 1,000 college kids and they have some net health decrement, some on average loss of health, but if that benefits other people, we should do that. But my understanding of vaccine policy has been that is a bedrock principle that we will never do, which is we will never impose a net decrement on some subpopulation, particularly young people, to protect another group of people, even if it were true. And in this case, I will argue, there is no credible evidence that boosting college kids who are in these bubbles on campus, boosting them is going to help
Right.
the old person in the nursing home. I don't think there's any evidence.
It's a philosophical question that sort of in some ways strays from what my expertise is. And, so I can only answer that as a human, and not in any other way, but I think that, and as a, again, as a physician, that um, the idea should be that with this vaccine, we have a very low risk profile, and that we are providing the most benefit, and that, if we have a situation in where we have a narrow therapeutic range for that vaccine, then we should be applying it judiciously and carefully, and without the use of, implied. And I would almost say that this is implied mandates, because we're not getting a mandate, but we're getting the situation where there is that small community groups have decided to mandate it on their small communities, and that is kind of the worst possible situation, because these groups don't have the expertise to know this. They don't have the
Correct.
expertise to review the data, and if you were running a small, I don't know, preschool or whatnot, and you insisted that, or a soccer club, and you insisted that everybody had to get a booster in order to play, and one of your players had an adverse event, that is what you did.
Yes. But I guess the question is, could you ever be successfully litigated? And I don't know the answer to that
No,
question.
no.
I don't think you can.
There's no,
Right.
obviously not. But I
Yes,
think
but you did it. Yes. But right now the University of California system has a booster mandate. It's coming soon. I will always do personally things at a net health decrement to me to keep my job, because I don't, if they told me at work they're going to punch me in the face a few times or I'm going to lose my job, I'll take a few blows. I'm not above it. I'll take a few blows. I'm not a principled person like that. But I will say the policy may be misguided, particularly for the young IT worker in healthcare, and it's not fair, not just. And we may look back in retrospect. And that's the other thing people forget. If you look back in retrospect and some portions of this policy were too heavy-handed, you have blown it. You think we already have a huge growing anti-vaccine faction in this country, and you're giving them ammunition for the next 25 years, and they're going to grow like you've never seen before. It's going to be a big problem for those of us who want to be critical thinking.
Well, I think historically there, again, and this is sort of somewhat out of my expertise, but there have been other events where there have been adverse events from vaccines widely, and they have led to a little bit more vaccine hesitancy. And so I think that as a pediatrician, my approach, at least to the patients, are not to insist or badger or say, well, you have to do this, but at the same time not to sort of overstress. The other side is just that it is definitely better to be vaccinated than not. That is because, and really in reality, the kids who are vaccinated are protected, and even though that risk of disease is still very low for them, it is much lower, much lower with vaccination. And so, the ideal scenario is to be vaccinated.
I agree with you. But let me push you on that point a little bit. 5 to 11. Do we really have evidence that vaccinating a 5 to 11 will lower hospitalization? It's an inferred from adult populations.
Right.
Okay. The next point I'll say.
I would say, we don't have evidence, and I wish we would. Right now, in the pediatric hospital that I work in, we are seeing, children who are being admitted, and it turns out that those kids are not the ones who are not vaccinated.
Yeah, but you know what we would say.
There's no study on that, but
correct.
I think
it's confounded by. I mean, I don't doubt that vaccinating 5 to 11 will lower hospitalization, but I do think that your experience is probably confounded by the kids in families that have chosen not to vaccinate are
Sure.
much more laissez-faire about life than kids in families that have chosen. In fact, those kids in families are living in a cocoon. Who knows what they're doing to them? They're the
Right.
ones that were first in line. They're still N95ing. They found some little kids N95. It's a really different sort of. Okay,
Right.
but that's well taken. But let me ask you these points. Los Angeles, 12 to 15-year-old boys. If they don't get 2 shots, they were going to throw them out of public school. That's a real thing. Thoughts?
I, you know, I it was as you know, it was sort of like thrown out, right? And I think it's it feels to me that it's the wrong way to go about that. Yeah, I think anybody would say that, that that's the wrong way to
Not
go about that.
anybody. I wrote my
Well, not
op-ed. I,
anybody,
I
right?
wrote my op-ed, and then I got this. This is my next point, and I got a big mountain of. I wrote my op-ed in U.S. News and World Report, and I got. Here's the question, and this is a true thing. Anybody who has talked about these issues or tried to study rates of vaccine-induced myocarditis have been labeled as anti-vax. That's very poisonous. I mean, for the ability to talk about this more openly and actually try to find some sensible middle ground. Thoughts?
Yeah. Yeah. I mean, I think that, I think about that exactly as I sort of mentioned that this is kind of a we've discovered that there's a little bit of a narrow therapeutic, and I sort of keep on mentioning this, a narrow therapeutic range for this vaccine, and we need to use it carefully and judiciously, and that's just a fact. And it's the same thing as, if there was a certain medication for heart disease that one would have to use carefully, it wouldn't mean that I don't believe heart disease exists.
Right.
It wouldn't mean that I think that it's better to get a heart attack naturally than to prevent it. No,
I think that medicine is digitalis. We used to detect digitalis levels, dig levels. And if you're
right.
and if you wanted to keep the patient in the proper dig level or the INR in the proper window, it doesn't mean you're anticoagulation. You just want him not to bleed to death, Yeah. Let me ask you this. Philip Krause, Miriam Gruber, they're number 1 and number 2 at FDA vaccine products. They have resigned. They worked there for decades. They've resigned over boosters. Should that give some people some pause that maybe we're leaping before evidence exists?
I think that Paul Offit and some of the folks have have mentioned that they don't support boosters. A number of people also, who are not just, those folks, not just Krause and the other gentleman who quit the FDA. There are a lot of people who feel with evidence that, the booster issue is a concern. And you're going to have to kind of edit this out, Vinay, because I'm losing my train of thought.
No, you're doing good.
It's a very sort of controversial kind of area, and I don't know what to, honestly. The real answer to that question is I don't know what to say about that.
Okay, let me take the heat. Here's what I'll say. I will say that if this had happened under Donald Trump, every single newspaper would have covered this as the top of the mast story. It happened under Biden. The president is not the person who should be making these decisions. If you're the president of the United States and you're in the White House and you work as the White House team, you have one goal, and that is that case tally of COVID-19 cases, that's got to go down. And it's got to go down before the midterm elections. It's got to go down before the next election. It's got to go down. And I don't care what it takes to get that number down. The last guy said the thing it takes to get the number down is to break all the tests. He was like, don't even test him.
Right.
And don't let him in. That's the boat. Okay, this guy, he doesn't have the same incentive for myocarditis. I mean, if there's no tally on the board of myocarditis. If myocarditis goes through the roof, they don't care as long as that case count goes down. The case count
I think they will care, but I was personally, and I think maybe I was naive, but when if you recall this hydroxychloroquine issue came out, that was the first time really that the choices of medications or the things that the doctors would do became suddenly politicized, and I found that to be shocking. It's just it's a ridiculous situation that we should be discussing this in terms of politics, and what medicine to use in terms of politics. It's incredibly destructive, um, and um, you know, I, I think that the most important thing is to kind of keep the politics out of it, um, and and make sure that we're just doing the best thing for the patient.
Let me read you something we wrote. Society faces a risk even more toxic and deadly than COVID 19, that the conduct of science becomes indistinguishable from politics. The tensions between the two policy poles of rapidly and systematically reopening society versus maximizing shelter in place and social isolation must not be reduced to Republican and Democratic talking points, even as many in media outlets promote such simplistic narratives. I wrote that in April of 2020 because I knew they're screwing it up, because the moment you make ivermectin Republican and, I don't know, tocilizumab is an independent and masking your 2-year-old as a Democrat, what are you doing? These are not, this is crazy. It's totally crazy, and it's going to poison it. And now it's too late. Now, at this point, I mean, school closure is the Democratic policy. Keep it closed and, mask them up at their house. And opening schools is the Republican policy. I mean, that's how it's been settled. I mean,
and it's not. It's and I might come. People might be upset with me to say this, but the fact is that when the schools were closed, they were closed in Republican states too for a long time. And people forget that. Then they were initially, yeah. But for a long time, in those states, there were bars and movie theaters and other things that were open while the schools remained closed. And, it sort of became a Republican Democratic kind of situation, but initially actually it wasn't. And,
correct. But I think one of the things that happened there was, I believe maybe around May 2020, DeSantis was one of the first people to reopen. And Fauci was quoted as being very critical of DeSantis, and that sort of further pulled people into that direction. And then Trump said strongly, I think in late April, we're going to have to open those schools. And the moment he says it, then, just to spite him, you'll say anything. You'll say the sun rises in the morning.
I do remember that, and I remember just the feeling of dread.
Yes, when he said it.
Yeah, just, oh my God, this is still things.
Vlad Kogan has public opinion poll data that shows the public opinion polling was kind of flat pro school. The moment he said it, it flipped it all, and incredibly partisan. Yeah. Okay, let's come back to the myocarditis. I guess one of the things I want to just get you to say is that many people say that myocarditis from getting the infection, or they say something like it's always worse to get COVID-19 than to get that there's no vaccine safety effect that could ever swamp the harm of COVID-19. Therefore, don't question existing guidelines. Your response to such a claim?
Yeah, no, I mean, I think my response is that if you have risk, you need to mitigate it independently of benefits. So, there are ways to mitigate it. You can get the same benefit. You just need to judiciously give the intervention. And it's sort of like you mentioned with the digitalis, you don't, it doesn't mean just sort of dump, a couple of tablets in, every 3 hours, into the guy's coffee. It means, let's just be careful on how we're doing it.
And then the next question for you is that other countries have reported that somebody has died from myocarditis post-vaccine. It's been reported in Singapore, in New Zealand. This country has not reported such an incident case from CDC, although our denominator is much bigger. How is that possible?
You got me, Vinay.
Yeah, I don't have the answer either. I don't have the answer either, but that concerns me. Next point. The CDC's estimate of myocarditis in these age groups is substantively lower than other countries' estimates. Maybe by 1 order of magnitude lower, maybe half an order of magnitude. Is our surveillance system the best in the world, our passive surveillance system?
I mean, I think it's obviously not, right? We know that. The VAERS is not a very good database. We don't have sort of a unified medical record system in this country that, places like Israel might have. Or many European countries, and so we can't tell. And I think but I really do believe that the idea about the number is not so critical because it's high enough. It's non-trivial, and it's further sort of deciding and arguing. Well, is it one in this, one in that? Is it actually a little bit more, actually a little less than the myocarditis that you get from infection, which again is important to remember that you do get that. So that's why vaccination is important. But I don't think the number itself matters.
Okay. I guess the only reason I think it matters a little bit, and hear me out, you're sitting in front of the 17-year-old boy, never had COVID, had one dose of Moderna, and this person is saying, should I get the second dose? So on the one hand of the scale, you're saying if you get the second dose, and let's say you're day 28, your risk of myocarditis is probably 1 in 3K. I think those are the highest estimates in the literature. If you don't get the second dose and you walk out there and you get Omicron, what's your probability you're going to be hospitalized? Is it 1 in 3K? And I think that's where you think about it a little bit. And that's, as you say, it can only be done, at an individual patient level. You need to know what's the person's BMI and what medications are they on, et cetera, et cetera. Right. But that's where it's relevant. And I think 1 in 3K is a heavy hand for such a boy who is totally fit.
Right. But you can space that vaccine
Correct.
Out.
And then you space it out it goes to 1 in 12K, 1 in 15K by pushing. Maybe.
So, I think you try to do that, as much as possible. But, and I think finally, the other point about this is, and I hope that I'm, came across as being, really nuanced about this and not, dogmatic on this. But I think that there is a dogmatism about this, that this myocarditis doesn't exist or it's not real, etc. And I think that is the same. It's as dogmatic as the idea that I'm never going to get a vaccine or all that.
Yes.
Whatever it is, it does. Unfortunately, it is there. And if we don't acknowledge that, one is that we won't take the steps that we need to do to mitigate it, and two is that eventually we're going to have to figure out some other vaccine for these adolescent males, because when you think about it, let's say we ever get to a situation where COVID is of very low incidence, it's not really going to be sustainable to be vaccinating teenage males at that point with that kind of adverse rate incidence. That's why the U.S. Army used to kind of vaccinate people against smallpox,
and they pulled it.
Stopped doing that because of that. And
that was what, 1 in 15K.
I think it was 1 in 10.
1 in 10.
Something like that. But
but your point's well taken. What are we thinking? 5 years down the road, 10 years down the road.
Right. I just think we need to not be dogmatic about everything, and everybody needs to stop being on a position in a corner that they won't think discuss anything, and just kind of say, well, look, these are the realities and they're okay. You can't fix problem without acknowledging the reality, and let's try to fix it.
Well, I will tell you what I think has happened over the last 15 years in culture. I mean, when I was growing up in the 1980s and 1990s, I don't think the anti-vaccine kind of movement was in its infancy, and it wasn't as powerful as it is today. And it wasn't even a controversial thing. You go to a doctor's appointment, you get your vaccines, and you go on. Okay. That contingency became stronger, and they said some things that were not true, and they published that disastrous Lancet paper that was, it wasn't even, I don't even know why people, it wasn't even science if you read it by its own standard. Mm-hmm. It was like a collection of anecdotes, and I would never have published it. It was garbage. But anyway, that got published, and that kind of fueled it, and then it kind of got bigger issue. Meanwhile, what was going on? We have widespread worsening income inequality, worsening income stagnation, wealth stagnation, political polarization. These forces are not independent of each other. The erosion of religion. You're taking away institutions from people's lives. You're preventing upward mobility. People will cling to all sorts of beliefs and groups that they can identify with, some new tribe. And now in the last 15 years, there's this reaction, which is the anti-vax movement. They're out there, fighting them tooth and nail and calling them names and, debunking the important stuff like, homeopathy and cupping, those big ticket items in modern healthcare that don't work, So they're spending all their time and they create their own tribe of people who feel virtuous and smart and smug about it, Okay. And then you introduce a new vaccine with a huge uncertainty, and then you get a new safety signal. And these two tribes, they can't process it. One is just like, anchoring to, the 80-year-old guy in the nursing home. He doesn't need a vaccine. I'm like, what are you thinking? You're out of your mind. You're going to kill this man. And then the other tribe is saying that 12-year-old boy, he can take 5 or, just titrate it to the troponin. It's like, no, what are you talking about? Like, what is their goal? They're crazy. And then they're like, oh, if it's FDA, EUA, if the EUA went through, it's got to be good. And it doesn't matter how many people resigned over this, it doesn't matter, so it's like just two delusions, and here we are in the middle trying to have a conversation in an environment where the social media landscape's just rewarding the crazies on both sides.
Yeah, no, I think, part of the reason that we've been talking, about stuff, for
privately,
a while.
Yeah.
But I think, part of the reason that I think it was important to come, to talk with you was, first of all, you are a legitimate, you've been academic medicine, you've excelled, and it's clear who you are, and and you're trying to kind of stick to the middle line, which is very, very hard to stick to. But I think people should try to, make a more of an effort to abandon those extreme positions, whatever they are, and recognize that it's an extreme position to say I'm not going to be vaccinated, and it's an extreme position to insist that a child has to get a booster when we don't have evidence for that. We just there is the reality is, yes, it is important to be vaccinated than not vaccinated, and we have to just make sure we're doing all of that carefully.
That's well put. Any other final thoughts on this issue that we didn't talk about? We talked about LGE. We talked about the unknown implications. I think we talked about probabilistic distributions. I think you nicely talked about life after COVID. I mean, a few years down the road, and how we'll have to rethink vaccination strategies in some ages with safety signals.
Yeah. Nobody can predict the future, right? I don't know how these things are going to...
Except the modelers. They're always good about it.
I imagine that it's probably going to be like this every winter. I think that we are going to have large COVID, Omicron peaks every winter. And given that, we need to, figure out how to be immune, and that means being vaccinated. And so, trying to be careful and really approach the patients, where they are to get them to do that. I think that's what we need to do.
What you said reminded me of one last question, which is, you talk about dogmatism. I think there's a little bit of dogmatism around one issue, which is how hard do you have to push on nurses, healthcare providers, RTs to get them vaccinated if they don't want to do it? And I think that, like, in a perfect world, they would do it. It's like,
Right.
Okay. But in a world where the hospital is about to collapse, literally about to collapse.
Yeah. Well,
just get your ass in here and we'll put a mask on you. Get in here. That's what I say.
Again, I'm it's something that's above my pay grade. So
Mm-hmm.
But I think that there's the question to me is why? Why, if you were working in healthcare, you would not get vaccinated?
Uh-huh.
And I understand that, you may feel that, well, I've been infected before, and therefore,
Sure.
I
That's
just
what's
don't want to do that, etc. But as a person in healthcare, really that your own risk, and the data for an adult is clear, that your own risk is really vanishingly small from being vaccinated, even if you've been infected before. I think that
It's
there's
nothing
something
to lose your
wrong.
job over. Yeah, I agree.
Oh,
But
it's,
I,
I
but
mean,
but
it's
but
crazy.
I'll
And
I'll tell you what I think there's a thing we're missing, which is that it's often related to class. Because physicians have, for the most part, have abided by the restrictions. We are paid hefty salaries, and we are a certain class. And then it's the people who do the other jobs who are not paid the same salaries, and it's a class issue. I mean,
I think that's,
yeah,
yeah, I think that may be in part true, but I think that that is a sign that there's something wrong with the messaging. I
yes.
think
Well,
that,
and society. I mean,
right.
I view it as like, I don't know. No one has really gotten to the bottom of these problems: political polarization, anti-vax. I think the problem is, if you were born as a blue collar town, like where I'm from, LaPorte, Indiana, you went to high school there, your prospects are so much worse than your father, your grandfather, your great grandfather. Your life is so much worse, and so the temptation of opioid addiction, and one of the few ways you can seize control over your body is this decision, right? It's like a way to take autonomy back from a world that's given you none.
I, and it's not something I hadn't thought about it in that way, but I think it's a reasonable thing to think, way to think about it. But and I think, and it's probably the last thing
Yeah.
before I have to go,
Yeah.
but
Yeah.
I was talking to a colleague way back in 2020 about this idea, my worry that, that there would not be enough vaccine uptake. And wondering, and at the time there was all of this, and it still is, but sort of this moralizing about, well, you're not wearing masks, you're a bad person, and the way to sort of encourage that was for somebody to come on TV and sort of wag their finger at people and say, well, you are being a bad person, and by not wearing that mask, etc. And my thought was, this is sort of a sociologic phenomenon. We can study this. Why don't we study how to get the best messaging across in
Right.
advance of the vaccine?
In a randomized study, right? Yeah.
Yeah,
Yeah.
yeah.
Of course.
Why don't we?
Yeah.
But we never did, and I think
No.
that that's sort of part of this whole. That is there's sort of these overarching themes are that something I said to Dave Zweig, is that people say, the reason that I see further is because I stand on the shoulders of giants, right? And that's why
Right.
we know all the things we do. But somehow in this pandemic, we just decided to get right off those shoulders.
we
And
didn't run
we
any
threw
good
out all the books. We said, oh, we're not going to do anything that we've been told to do. And that's where we are.
And Mark, there's one more thing. All those people who used to come on in 2020 and said, wear your cloth mask, you bad person. Now they're on TV saying, whoever told you to wear that cloth mask? That don't work.
Right.
I'm like, what are you doing? Now they're like, oh, N95s are the only thing that works, which has been true the whole time, but okay,
Sure.
fine. Now you're admitting it. All right. Yeah, I knew that. Yeah, okay. All right. Mark Gorelik, thank you so much for doing this important dialogue. I think if the goal of the conversation is not to know the answer, it's so that people can actually talk about this and take these questions quite seriously. So I think that's the goal. Thank you so much.
Cool. Thank you.